Hello, I'm Phil Jacobus. It's July 28th at 2 o'clock in the afternoon, and I'm here in my office in New York City. Thanks very much for joining me. Today, I'm joined by Dr. Alexander Towbin, a Cincinnati Children's Hospital radiologist and expert on standardization. But before we visit with Dr. Towbin, let's take a brief moment to catch up on a couple of the latest news items in healthcare business news online. Here's a story. We see that a quarter of the CT scanners in Ireland have exceeded their end of life. Interesting. Next, from our July 2020 print magazine, there's a story on breast imaging products and how they're helping with coronavirus backlog. This is an extensive review of breast imaging, and if you missed it in the magazine, it's a worthwhile read. As always, I encourage you to sign up for our free online news. I promise you, you won't be sorry you did. You'll be the most knowledgeable person at the water cooler. And now, let me welcome my guest, distinguished Dr. Alexander Towbin. So welcome, Dr. Alexander Towbin. Dr. Towbin is a professor of radiology and associate chief of radiology at Cincinnati Children's Hospital. And he is an expert on standardization. So Dr. Towbin, thanks so much for joining us.
Thanks for having me. I'm glad to be here.
You know, Dr. Towbin has a lot of interesting content in our magazine and in our online news, and you'll see links to those pieces in the story. So afterwards, don't forget to click. So Dr. Towbin, just for from 5,000 feet in the air, talk about standardization just for a minute, if you would.
Okay. So standardization is the same people doing the same thing repeatedly. And so doing it consistently over time. And it's helpful as we're implementing different processes or different technology to be able to have that reproducibility and that consistency. It gives us predictability in the type of operations that we want to do or the procedures that we want to do. And it's a tool that can be used in safety purposes.
And a practical application of that, I know in some of your writings, I might call it the upper arm and you might call it the femur.
Yeah. So one of the projects that we are working on currently is how do we standardize our terminology for body parts. It's specifically related with enterprise imaging. And so some of the work that I've been doing with the HIM-SIM enterprise imaging community is making enterprise imaging more accessible and making it more real for each of our institutions. And one of the things that we think is really the key to unlock the power of enterprise imaging is using body parts to help to label those images and to make them accessible to the different specialists throughout the medical enterprise. And so, like you mentioned, what do we call this? So when I flex my big muscles, this muscle or this part of the arm, the radiologist calls the humerus because that's the bone under it. The orthopedic surgeon may call the upper arm, or they may refer to the muscles like the biceps and then the tendons and even the shoulder around it. The dermatologist would refer to the skin surface of the upper arm. And so all of those are the same thing. It can refer to the same thing, but they are different words. And for us to use those words effectively to pull up images, so that when the dermatologist takes a photo, it needs to have linkages in some way to a subsequent MRI or a subsequent operative photograph, or even a pathology photograph, to be able for the end users to consume those images. And we're all end users in that sense. We all consume images in different ways from different specialties, but we all also produce images. And so the challenge is how do we use that terminology effectively to do it simply? So we don't want to add a lot of clicks. We can't all know 200,000 or 500,000 different terms for body parts, and making sure that there's that relationship. So those are some of the challenges that we're trying to solve as we try to standardize that language with enterprise imaging.
In a way, it makes me think of Esperanto, but you know, you're overcoming tradition and you're overcoming habit.
Yeah.
how do you, how can you have one word, or can you have one word that satisfies the dermatologist, the radiologist, and the physical therapist?
So I don't think so, is the easiest answer. But what we can do is have a terminology set that has a relationship. It doesn't make sense for the radiologist is seeing the humerus. We're not, depending on the type of imaging study that we're doing, but we're seeing the humerus or the upper arm. Or if you go into the abdomen, we're seeing the abdomen in its entirety. Whereas a surgeon maybe is seeing just the liver as he or she is performing an operation, or they're focusing just on the liver, or the pathologist has a piece of the liver. So the need for different levels, there is a need for different levels of specificity. But knowing that the liver is a part of the abdomen is important. And so having that type of relational database or relationship within the terms is important. Same thing on like the hand. So I may call this part of my hand a small fingernail as a dermatologist. And a radiologist, we're taking an x-ray of either the finger or the entire hand. And so having the different levels of specificity is again important.
You know, I was going to ask, what are the obstacles you face, but I think it's almost too obvious to ask. So let me ask, if you had to give some advice to an institution or organization or the industry in general about how to overcome or rectify or organize this situation, what would that advice be?
It's been a challenge at each institutional level as we're trying to implement enterprise imaging. And so what we're trying to do nationally is get to some decision to not to come up with a new language, but to pick one language that already exists, and then to start using that language. So there are things out there, different terminology data sets. SNOMED CT is an example of one, or LOINC has one. There different sets are out there. And so as an industry, can we just select one and then make sure it works? So if you are starting off and need to implement something like this today, I would say pick something that already exists, something that's up to date and can be used going in the future. Each institution will have to pick the level of specificity that they want to use, or how much they care about the different details. If everything in the, above the neck becomes head and neck and just labeled as head and neck, that can work. If you just may lose some of more detailed needs later on. But I would start with the general terms and move specific.
Is there, is it HIMSS or RSNA or what, what organization do you think will take the lead, or will there be no one organization take the lead?
What we're hoping to do is we're trying to build towards what we're calling a body part summit through the HIMSS-SIM enterprise imaging community. So that's the Health Information Management Society and the Society of Imaging Informatics. And together in that community, building towards a decision, but bringing in specialists from many different societies. So we're working to try to convene, but not be the one deciding group.
And my last question, who benefits and how do they benefit? If you could wave a magic wand and have a universal language, who would benefit and how would they benefit?
I think we all as medical providers would benefit. The goal to be able to do this is, the primary goal is towards image consumption. So wanting to be able to say, when I click a link in my electronic medical record, that it opens up the study and then anything that's relevant with it. And so in the radiology world, that could be another imaging study, but it could also be pathology or a surgical photo or a wound photo. All those things can provide me with important information as a radiologist as I make a diagnosis or work on follow-up imaging. And that's true with every specialty. And what's relevant for every specialty is unique to that specialty and sometimes to that provider. Secondary people who can benefit would then be researchers. So if we've categorized the information consistently and in a standard way, it can be brought out, and that can help us to do things like derive artificial intelligence algorithms to be able to use that data in a better way. We have more specific labels on it. It helps with that up front. So that can ultimately, all those things can ultimately toward better patient care, and so that's where the patients benefit.
Right. Well, that's the bottom line, isn't it? Better patient care.
That's the hope, yeah.
Right. Well, Dr. Towbin, you are a smart, you're dazzling me with your knowledge of this topic, and I hope that you'll come back and join us again in a few months after that task force has met and maybe something came of it. Thank you very much for joining me today.
Yeah, thanks for having me on. I appreciate it.